Welcome, colleagues. Today we're going to take a hard, consultant-level look at a decision we make all the time in trauma surgery: how to fix an intertrochanteric fracture. We're going to move past some of the old dogma and really dissect the latest high-level evidence comparing the sliding hip screw and the intramedullary nail.
All right, so here's how we're going to break this down. First, we'll frame the dilemma itself. Then we'll get on the same page about the two core fixation philosophies. We'll look at the standard of care for stable fractures, then dive headfirst into the debate on unstable patterns. After that, we'll synthesize some really powerful new evidence and wrap it all up with how this informs our real-world surgical decisions. So let's set the stage. We all see these fractures constantly, right? They're incredibly common, especially in our older patients. And the implant we choose has real, tangible consequences for their recovery and their future. And that really brings us to the million-dollar question for this whole explainer. When can we say with confidence that an intramedullary nail is actually definitively superior to a sliding hip screw? We're going to look past what we might have been taught and really see what the best evidence today is telling us.
Okay, next up, before we can even begin to compare outcomes, we've got to ground ourselves in the fundamental principles of these two devices. They're not just different pieces of metal, they work in completely different ways. So you've got your two main players in the game. On one side, you have the workhorse, the extramedullary sliding hip screw, or DHS as many of us call it. On the other side, you've got the intramedullary nail, the PFN, the CMN, all its various flavors. And here is the absolute crucial difference. The SHS sits on the outside of the bone. It's a load-bearing device, essentially acting as a lateral tension band. The IM nail, on the other hand, goes right down the medullary canal. It's an internal splint, a load-sharing device. And that theoretical load-sharing ability is precisely where its supposed biomechanical advantage comes from, especially when things get unstable. Now, let's start with the easy stuff. When we're talking about stable fractures, the evidence has been pointing to a very clear answer for a very long time. Look, for your standard, stable, two-part intertrochanteric fracture, your classic AO/OTA 31-81, the sliding hip screw is the gold standard. It just is. Multiple systematic reviews have shown time and again that it's not only effective, but it's also the cost-efficient choice for these patterns. Okay, now for the main event. Let's get into the unstable fractures. This is where things get really interesting, where you've got comminution, a blown-out lateral wall, or that tricky reverse obliquity pattern. This is where the real debate lies. From a pure mechanics perspective, the case for the IM nail in these unstable A2 and A3 patterns is pretty compelling. Because it's a load-sharing device, it has a shorter lever arm, which cuts down on the bending forces at the fracture site. Its position inside the canal is just inherently more stable, and it's specifically designed to fight against those classic failure modes we all dread: varus collapse and medialization. And this isn't just theory, right? The clinical data backs this up. Take this 2018 meta-analysis by you and colleagues. They looked specifically at unstable fractures and found that intramedullary fixation led to lower rates of implant failure, fewer re-ops, and even better hip mobility for the patient after surgery. So when you start to pull all the data together, just for these unstable fractures, a really consistent picture emerges. The evidence really points to the nail. You've got lower implant failure and reoperation rates from that meta-analysis. Then you look at surgical metrics from other reviews like Patel's, and you see nails are often associated with a faster surgery and less blood loss. For this specific, challenging subset of fractures, the argument for the nail seems pretty strong. But, and this is a really big but, that's not the whole story. This is where the narrative gets much more complex. Some recent, very high-quality evidence has come out that adds a layer of nuance that I think is truly practice-changing. So first, let's talk about this big meta-analysis that came out of Rutgers in 2023. This was a massive undertaking looking at over 3,300 patients. And here's the critical part. They didn't just look at unstable fractures. They analyzed outcomes across all intertrochanteric fracture types, stable and unstable alike. And what they found was, frankly, striking. I'll quote it directly. Treatment of intertrochanteric femur fractures with SHS demonstrated significantly fewer refractures and reoperations. So when you zoom out and look at the entire patient population, the good old sliding hip screw actually came out on top for two of the most critical complications we try to avoid. And that leads us to the real heavy hitter here, the INSIGHT trial, also from 2023. This is a landmark study. We're talking about a huge, multi-center, international RCT with 850 patients. This is about as definitive as the evidence gets in our field.
So what was their primary outcome, the one that matters most to the patient? Their health-related quality of life 1 year after surgery. And the result? Absolutely no difference. The more complex, more modern, more expensive implant showed zero benefit in how the patient actually felt and functioned a year down the road. And that finding becomes even more powerful when you think about the money. As the authors of Insight point out themselves, these intramedullary nails can cost up to 40% more than a sliding hip screw. When you have no difference in patient quality of life, a cost gap that big becomes very hard to ignore. So, what on earth do we do with all this? We've got biomechanical theory and some studies pointing one way, but then we have this massive high-quality trial that seems to point another. How do we put all this together when we're standing in the OR?
Well, I think the synthesis of all this evidence points to a much smarter, more stratified approach. Your SHS is still your reliable, cost-effective workhorse for stable A1 fractures, and that Ricker's meta-analysis shows it performs exceptionally well overall, with fewer re-ops across the board. The IMN is a powerful, specialized tool whose biomechanical strengths are best reserved for the truly unstable patterns, your A2s, A3s, reverse obliquities, the ones with a shot lateral wall. But the Insight trial reminds us that this mechanical edge doesn't necessarily translate into a better quality of life for the average patient. So the verdict isn't really IMN versus SHS. The real question we should be asking ourselves is, when do I truly need to use an IMN?
And that's the final practical question I'll leave you with. As surgeons who are also stewards of healthcare resources, how do we balance that significantly higher cost of a nail against advantages that appear to be very specific rather than universal? That's the challenge for all of us in our day-to-day practice.